Thank you everyone for attending today's CE webinar. I also want to thank everyone for sending in future speaker requests after the last webinar, and I continue to think about other speakers and topics you would like to hear throughout the year as we try to do this from a monthly perspective. I also want to let everybody know that we've heard from the members, and the CE committee is looking into finding ways to do this to a broader audience, and that might include looking at different times and different day options for future webinars, starting with the May webinar. So that being said, let me introduce Dr. Laurel Redding. She is an assistant professor of epidemiology in the Department of Clinical Studies at the University of Pennsylvania School of Veterinary Medicine. She grew up in France and did her undergraduate at Duke University and obtained her veterinary degree as well as a PhD in epidemiology at the University of Pennsylvania. Her focus for research is to understand the epidemiology of antimicrobial use in veterinary medicine, the One Health implications of antimicrobial prescribing, and the role of pets and livestock as reservoirs for zoonotic pathogens, such as Clostridial difficile. She continues her clinical work with small animals on a relief basis and became board certified in preventive medicine in 2019. Welcome, Dr. Redding.
Hi, thank you, everyone. I really appreciate the opportunity to be here. I'm going to go ahead and get started on the presentation. So once again, thank you for this invitation. I'm really excited to be here and just really excited to talk to you all about antimicrobial stewardship in veterinary medicine, because it's a fascinating topic, and it's a relatively new topic, but it's garnering increasing interest among veterinarians, because there's a recognition that we as veterinarians do contribute in prescribing antimicrobials to the global phenomenon of antimicrobial resistance. And so I'm not going to be talking to you today about how antimicrobial resistance is a pressing global concern and how it's the quintessential One Health issue, because you all already know that, and having studied for the ACVPM and in doing what you're doing on an everyday basis, you all already know that. So instead, what I would like to do today is really provide kind of an overview of the literature on antimicrobial stewardship in veterinary medicine. I'd like to also discuss how we as veterinarians can contribute to antimicrobial stewardship, both as practitioners, but also as mentors and teachers of the next generation of veterinarians, and pretty much just explore what shape antimicrobial stewardship can take in veterinary medicine. So to start off, what is antimicrobial stewardship? Again, hopefully this is something you all know, but I'll just walk you through some of the definitions that exist. And there are different flavors of what antimicrobial stewardship is. So on the one end, we have coordinated interventions that are designed to improve and measure the appropriate use of antimicrobial agents by promoting the selection of the optimal antimicrobial drug regimen, including dosing, duration of therapy, and route of administration. And this mouthful, basically, I highlighted the important phrases, I think, which are appropriate use and optimal drug regimen. On the other end of the spectrum, antimicrobial stewardship can also refer to the commitment to always use antibiotics appropriately and safely, only when they are needed, and to treat disease. So, the reason there are different flavors are because they can apply at different levels. So this first definition here with the coordinated interventions, this is something that I would see applying to the institutional level, right? In the setting of a hospital is going to create these coordinated interventions. A commitment to use antibiotics appropriately, that's something that happens more at the level of the individual, right? The individual practitioner committing to improve their own prescribing to make it as judicious as possible. So when we think of antimicrobial stewardship, most of the times we think of formal programs such as those that are seen in human hospitals. And these have things like a multidisciplinary team that includes a clinician, a pharmacist, a clinical microbiologist, an infection preventionist. And they have initiatives such as limiting their formulary, having institutional guidelines, processes to measure and monitor antimicrobial use, and the use of antibiograms to monitor resistance within the hospital setting. And in fact, the CDC actually considers all of these components to be the minimum requirements for an antimicrobial stewardship program. Now, to my knowledge, there are no antimicrobial stewardship programs in veterinary medicine that have all of these components. And a lot of it has to do with the fact that not many hospitals, for example, have all of these members of the multidisciplinary team that can commit their resources to a stewardship program. Therefore, while we can certainly draw on many years of experience acquired in human medicine stewardship programs, inevitably, antimicrobial stewardship in veterinary medicine will look different. So the next question, or the first question we need to ask, is whether antimicrobial stewardship is actually needed in veterinary medicine. And hopefully you'll all already know the answer to this, but I do want to go through some studies that have evaluated antimicrobial use in veterinary settings, because in order to know whether we need to improve it, we need to know, first of all, how antimicrobials are currently used. And so this is one example of a study, and this was conducted by Banfield. And as you probably know, Banfield is a network of small animal hospitals. They have, I believe, over 800 hospitals throughout the United States and Puerto Rico. And so they have this huge set of electronic medical records that they can draw on for really neat epidemiological studies. And this was one study that they did looking at antimicrobial prescribing in dogs. They looked at 3 conditions of interest: canine urinary tract infections and bacterial respiratory tract infections. And they looked at what veterinarians in their network were prescribing. And so they looked at choice of drug, they looked at dosage of drugs, and this is the kind of graph they produced. And you can see here the top, for amoxicillin being dispensed for canine urinary tract infections, a lot of the dispensation followed guideline recommended dosages, but there were quite a few that were substantially over the recommended dosages. For canine bacterial respiratory tract infections, it was the minority of dispensations that followed actual recommended dosages. So already here we can see a discrepancy between what's actually prescribed and what's recommended. Banfield did another follow-up study looking at feline conditions in antimicrobial prescribing, and they looked at urinary tract infections and URIs as well. And you can see here, just from this first graph down here at the bottom, there was a large number of cats that received antibiotics with no urinalysis or negative urinalysis results. If you go down here to the bottom of this figure on the right, there's a majority of animals that received culture sensitivities that had no growth and yet continued to receive antibiotics. The summary statement from this report also noted that only 7% of URI and bacterial bronchitis episodes were treated with a guideline concordant antimicrobial. So this definitely suggests that we have some work to do in terms of making sure our prescribing is judicious as possible. There were other studies too that occurred in other countries, which may not be as relevant to us, but probably are generalizable to us. And again, this one in Switzerland looked at antimicrobial prescribing in cats, and they found that prescriptions followed guidelines in only 22% of cases for URIs, 24% for feline lower urinary tract disease, and in 29% of abscesses. And they found a fair amount of unnecessary prescribing in 34% of URIs, 14% of fluid cases, and 29% of abscesses. And if we move on to the large animal side, one study in Australia looked at prescribing for surgical prophylaxis, and they found a fairly large number of cases where either the timing, the dosing, or the duration of antimicrobials prescribed for these different conditions was quite prevalent. And so hopefully, you'll recognize that while, most of us probably try to prescribe antibiotics as judiciously as possible, there is a lot of room for improvement. So I would answer that, yes, antimicrobial stewardship is certainly needed in veterinary medicine. So one of the things that I fall back on next is that all of those studies I showed you They were objective data on antimicrobial prescribing where some investigator looked at data and they made a judgment call about whether those other veterinarians' use was inappropriate or not. But what do vets themselves have to say about this topic? Well, it probably will come to you as no surprise that vets do acknowledge that antimicrobial prescribing is not always as good as it can be, and that there's a lot of room for improvement. So a colleague of mine and I, we recently interviewed some veterinarians from my institution, University of Pennsylvania, about their perceptions of antimicrobial prescribing in veterinary medicine. And here are some of the things they had to say. Basically, they're talking about themselves and their colleagues. One clinician said, perioperatively, I think we put too many cases on antibiotics and I think we keep them on them for too long. And I think also when you're treating an infection, we probably have them on too long for that too. Another clinician or resident said, I think a lot of clinicians, not necessarily here, but around in the field everywhere, just put animals on antibiotics just because with no objective evidence that the animal needs the antimicrobials. And then a small animal faculty member said, I think even in our hospital, although we are a paragon of excellence in many areas, we do need to work more on antimicrobial stewardship. And we do have a committee who are doing great work in this area, but I see on a daily basis aggressive and sometimes what I deem to be suboptimal use of antimicrobials. So we have both objective and subjective data suggesting that antimicrobial stewardship is needed. The next question to ask is, if we've established that antimicrobials are sometimes used inappropriately in veterinary medicine, we really need to determine why they're used inappropriately. And fortunately, there have been a lot of studies in veterinary medicine that have examined the drivers of antimicrobial prescribing at the level of the individual clinician. And this is both large and small animal veterinarians. And these are some of the most prevalent reasons why veterinarians cite for not always prescribing inappropriately. We have cost issues, lack of knowledge, perceived ability of clients and client pressures, time pressures, defensive medicine, and diagnostic uncertainty. There are other factors, of course, but these were kind of the main ones that came out in all of these studies cited here below. And so I wanted to walk through some of these and determine if some of these barriers to appropriate prescribing can be addressed by antibiotic stewardship initiatives. And I wanted to start off first with lack of knowledge, because in some cases, there is a lack of knowledge for how to best treat a patient with antimicrobials. It could be because a veterinarian is new to clinical practice and just isn't sure how to treat a specific condition. It could be because the recommended treatment is vague. I'm sure you all looked in plums and seen a huge range of doses or durations of therapy that are recommended, and it's hard to know what to do in those cases. It could be because the vet just isn't sure what's going on and not exactly sure what they're treating. And so while lack of knowledge is probably not the main reason in the majority of cases where antibiotics are prescribed inappropriately, a lack of knowledge of how to treat is sometimes a reason, and this is really a low-hanging fruit that can be addressed by education of clinicians. So for example, there are guidelines for prudent antimicrobial use that not all veterinarians know about. And the AVMA, for example, has released a set of guidelines. And you can imagine that the task of the AVMA was very difficult in developing these guidelines, because they basically had to come up with a one-size-fits-all kind of statement that would apply to treating individuals therapeutically, as well as treating herds prophylactically. So of necessity, these guidelines were very high-level guidelines that would be applicable for most situations. And you can read through them here, but I want to highlight a couple of them. This one here, for example, regimens for antimicrobial prevention, control, and treatment should be established using accepted scientific and clinical principles. I should think this is a tenet that no one's going to argue with, right? No veterinary clinician is going to knowingly prescribe an antibiotic without using accepted scientific and clinical principles. So it's a good guideline to have, but perhaps not terribly useful when you have a sick animal in front of you or a herd of animals facing an infectious disease outbreak, and you're kind of trying to figure out what to do. This one here, is another one. It's so, again, hopefully something that none of us would argue with you, right? You think that the duration of therapy should be based on scientific and clinical evidence. We want to prescribe antimicrobials for a duration that's consistent with scientific and clinical evidence. But the question comes up, what happens when that evidence doesn't exist? Okay, there are very few studies that provide scientific evidence for how long a course of antimicrobials should last for specific conditions. So again, this can be a real issue here. Nevertheless, these guidelines are good aids for getting clinicians, especially clinicians just starting out, to just start thinking about and getting into the right frame of mind for prescribing as judiciously as possible. Other groups and researchers have come up with additional guidelines for rational antimicrobial use that either agree with or complement the AVMA guidelines. This publication, for example, had a series of principles that were somewhat more specific than the AVMA guidelines. For example, I really like this middle tenet here that talks about indications for when a culture and susceptibility testing should be performed, when it really be necessary to ask that client to spend the additional income to run this test. And this kind of guideline can be really useful in improving the knowledge of clinicians to promote judicious prescribing. Another set of guidelines that are even more helpful are those that are geared at specific conditions. And so the ISCAID, or the International Society for Companion Animal Infectious Diseases, has developed a set of pretty solid evidence-based antimicrobial use guidelines for specific conditions in dogs and cats, including upper respiratory tract infections, urinary tract infections, and bacterial folliculitis. And these guidelines provide information on when to treat, what to treat with, how long to treat with, and they're continually updated when more evidence emerges. So for example, for UTIs, these guidelines provide recommended drug choices for uncomplicated and complicated cystitis with recommended durations of therapy that are generally shorter than what was previously recommended, less than 7 days for an uncomplicated cystitis, which is a lot more in line with what's recommended in human medicine, for example. So when I teach our vet students about judicious antimicrobial prescribing, especially for those who plan to pursue small animal clinical practice, I really make sure they know that these guidelines exist and that they're something they should have in their back pocket when they start out in clinical medicine. Surprisingly, not many clinicians are aware that these kind of guidelines exist. So I hope that, if you're not already aware of these guidelines and if they're relevant to the type of practice that you do, that you will become familiar with them and circulate them among your peers, because they're really, really useful. Other sets of antimicrobial use guidelines exist as well, with specific recommended treatments by species and disease. Ohio State has put together a really nice comprehensive set of guidelines that are used in their hospital, and they've been made openly available to anyone. So this is another resource that can be really useful in boosting knowledge of veterinarians about judicious antimicrobial use. And again, unfortunately, while these guidelines are comprehensive, there's limited information on duration of therapy, but that again has to come back to the fact that there just isn't much evidence out there to guide duration of therapy. But these guidelines can nevertheless be really useful, and they were developed based on the collective experiences and knowledge of clinicians who've been doing what they've been doing for a very long time. So the next obvious question is to ask, does having antimicrobial use guidelines actually help in promoting judicious antimicrobial use and decreasing unnecessary use? Well, there have been a small number of studies that have looked at the effect of the formal introduction of guidelines on antimicrobial prescribing within hospital settings. None of them have occurred in the United States, unfortunately, but they can nevertheless be useful for us in terms of demonstrating proof of concept. And you can see in each of the cases, the introduction and dissemination of guidelines resulted in substantial decreases in prescribing, either in overall prescribing or in unnecessary prescribing for specific targeted conditions. So this certainly seems to suggest that the introduction of antimicrobial use guidelines can be very useful in achieving more judicious prescribing. However, The bottom line here is that when it comes to guidelines, a lot more research is needed to develop these evidence-based guidelines. And I did want to take a minute to just discuss some of the efforts that are currently underway when it comes to developing these guidelines. And first off, perhaps the simplest, but by no means the easiest way to compare antimicrobial regimens is with observational studies. And as ACVPM diplomats who diligently study epidemiology to pass through the boards, you should remember that an observational study or a non-interventional study has its limitations because essentially the investigator can't control the circumstances under which different antimicrobial regimens were administered. But they can nevertheless provide us with some indications of how different regimens compare. And these two studies up here are examples of observational studies that examine the question of whether similar outcomes could be achieved when either antimicrobials were prescribed or not prescribed for different conditions. And so this first study up here looked at arthroscopy in horses, and they found that the rate of joint infections was similar whether the horse received antibiotics or didn't. So that's a really interesting finding. This second study down here looked at outcomes associated with canine acute diarrhea and animals that got or didn't get antimicrobials. And they found that outcomes were broadly similar. And so they're suggesting that antimicrobials are probably unnecessary for acute cases of diarrhea. And these types of studies, they give us good grounds for conducting follow-up studies to more rigorously evaluate the hypotheses that antibiotics may or may not be necessary for specific conditions. Another thing we can do with observational studies is to compile them into a systematic review or meta-analysis to begin to develop hypotheses that can be further tested to develop our evidence-based guidelines. So this project here is one that some colleagues and I are working on, and we're looking to compare different antimicrobial regimens for regional limb perfusion in horses. And so we, searched the literature for all the trials and studies that use different antimicrobial regimens for equine regional limb perfusions, and we examined the effects of different factors on whether or not therapeutic levels of antimicrobial were achieved in the perfused limb and the perfused joints. And we were able to tease out some general features that could potentially be integrated into future guidelines, such as the use of a wide rubber tourniquet is preferred, high volume is superior, and the use of a second distal tourniquet for proximal structures achieves better levels. So that's another way that the literature can be leveraged to develop guidelines. And finally, of course, the gold standard when developing guidelines is to do clinical trials, directly testing the hypothesis of interest. And there are initiatives underway in various institutions. So for example, the FDA recently came out with this request for applications to fund studies to help define duration of use for different antimicrobials. And they funded 2 studies to look at duration of tylosin for liver abscesses in cattle and duration of chlortetracycline for bovine anaplasmosis in cattle. And then we have other more targeted clinical trials at my own institution. We're doing this one study right now where we're comparing a 2-week versus a 4-week course of antibiotics for dogs with pneumonia. And there's another study ongoing looking at metronidazole versus no metronidazole for dogs with diarrhea. And it's these types of clinical trials that are really going to be useful in setting these guidelines. So while there still is a long way to go before having comprehensive guidelines for many specific conditions, just keep in mind that there are efforts underway, and so make sure to stay tuned to the literature for advances in knowledge from these areas. So let's look at the next factor. If lack of knowledge was one factor driving inappropriate prescribing, let's look at another thing that affects inappropriate prescribing, and some of these are client related. I'm sure most of you have stories about why or why not you may have prescribed an antimicrobial that you didn't feel 100% comfortable with giving, but it was something that that client really wanted. And, maybe that client threatened to go see your competitor if you didn't prescribe it, or Or maybe, you had that client with a cat and the cat was a horrible cat to pill and the little old lady didn't want to have to pill it. So you gave it a shot of Convenia, even though, the indication was probably not right for Convenia. I know that's happened in my experience. So I'm sure other people can relate. But let's talk about a little bit about how some of these issues can be addressed in antimicrobial stewardship. And it's a universally acknowledged phenomenon. And in different studies where veterinarians were interviewed about what drives their prescribing and whether they feel pressure from their clients, veterinarians have said things like, I constantly feel pressure to prescribe antibiotics for clearly viral infections and abnormal urinary signs. I had one person demand I give her cat Baytril last week because she was told it was the best antibiotic ever. Another veterinarian says, I think everyone does feel pressured to prescribe antibiotics and they'd be lying if they told you otherwise. I think a lot of pet owners just want to do something for their sick pet, but if they were somewhere else where the other doctors always did this and it worked, that's where it particularly becomes an issue. And this third quote down here comes from a study out of the UK, where a veterinarian said, there's a pressure when an owner comes in and pays 35 or 40 pounds for a consultation. They want to go home with a medication that, quote unquote, fixes their animal. So there's definitely a true perception on the part of veterinarians that clients want antibiotics and are pressuring them. But as you'll see in the title of this slide, sometimes perceptions can be different from reality. And there's been some really fascinating research in human pediatrics to examine whether perceived parental pressure for antibiotics, which is analogous to our perceived client pressure, actually exists. And so social scientists and behavioral scientists have examined the interactions between parents and pediatricians where there was perceived pressure to prescribe antibiotics. And in one study, the investigators came away noting that the perceived pressure might not actually be real. And things that pediatricians interpreted as being pressure for antibiotics were in fact just things like parents seeking information rather than pressuring. So it does behoove us as veterinarians, when faced with the client that we perceive as pressuring us for antibiotics, to really step back and examine whether the pressure is real or perceived. And so a colleague and I conducted a study where we interviewed pet owners in different small animal veterinary clinics. And in response to a hypothetical situation where a pet was sick with an infection, but the vet told the pet owner that their pet did not need antibiotics, almost all of the pet owners expressed acceptance and complete trust in their veterinarian. And, we had they said things like, I guess I would honestly just defer to their professional experience. If they said no antibiotic, I'm not going to fight somebody that went to vet school. And then my personal favorite down here, I go by the vet's judgment. I don't ask her anything about driving a truck and she doesn't ask me about being a vet. This confirms, obviously, we have issues here with reporting bias potentially in a small number of people, but I suspect that the willingness of clients to go along with what their vet states is probably greater than we give ourselves credit for. And so that's just something to think about when we're prescribing. And to go even further on this spectrum, this one study out of the UK, there was one participant who noted that that she thought that the veterinarian was actually the one pushing the antibiotics. And obviously, I think this is a minority opinion, but this is just something to think about when we're faced with a perceived pressure to prescribe an antibiotic that we might think not necessary. So while I certainly don't deny that client pressure can occur, these studies suggest that it might be beneficial to back up, pause, rethink the situation, and really try to think about whether these client pressures should or shouldn't be driving our prescribing. And so if you remember back to the Antimicrobial Use Guidelines I posted earlier in this presentation, one of the recommendations was that clients should be educated to ensure compliance with administration of regimens. And this is obviously easier said than done, especially when we have limited time available to spend on education of our clients. But luckily, there are many groups that have put together some truly excellent client educational material to promote judicious antimicrobial use. And this is just a small subset of the groups that have material that's available to clients. But there really is a great wealth of information out there that can be used for client education. However, with this, I issue a caution. Educating clients can be difficult, and especially if you're relying on passive education, things like visual material and brochures. I recently conducted a study where we posted these posters that were produced by the AVMA on the walls of exam rooms in veterinary hospitals and assessed whether clients noticed them and were able to retain their message. And the results were pretty bleak. I think it was somewhere like only 11% of people who participated in the study actually noticed and could either partially or completely retain the message of the posters. And similar studies in human medicine have shown that passive education like this is not terribly effective alone. However, of course, in coordination with other initiatives that involve education, they do have a role to play. So what other options are available to us to educate clients? This was a really neat study that examined how well fear works in getting people to change. And so this was a study conducted where people were randomized to receive one of 3 fear-based messages about antibiotic-seeking behavior for influenza-like illnesses. And I'll read you the text of the third arm. People were told, most people get cold or flu symptoms every year, and they usually get better on their own. Temperatures sometimes last for days, while coughs can last for weeks. Antibiotics should not be taken for cold and flu symptoms. Taking antibiotics encourages bacteria to become resistant. Some killer diseases are already resistant to several antibiotics. Antibiotic resistance is an increasingly serious threat to everyone's health, and soon we will not be able to find antibiotics that can cure serious illness. Even worse, without antibiotics that work, even minor injuries and routine operations will become increasingly dangerous. You can pass on resistant bugs to people you care about. So really fear-based messaging. And after receiving this message, these patients were asked, how will this information affect the likelihood of you asking a doctor for antibiotics if you were to visit for influenza-like symptoms? And all 3 messages produced a marked decrease in the antibiotic-seeking behavior of patients, with the greatest decrease being achieved with the strong fear and empowerment messages. So this is just a really neat tactic, I think, that could be used to limit these client pressures. And another technique that has not been tested to my knowledge in any sort of trial, but has found to be anecdotally effective among veterinarians that we interviewed, is that of stories. And this particular veterinarian said, I think people like stories. More of this happened because of that, or we could have avoided this if we didn't use that. More of look at Fluffy at exposure, overexposure to antibiotics, and this is what resulted because now we have this infection we can't treat. I think that it hits home more. People remember stories. And there is a huge literature out there about how stories can be really effective in getting a message across. So, this is certainly something that I've used sometimes in cases of clinical cases like this. Another method that can be very powerful in dealing with client pressures, whether real or perceived, is that of delayed prescribing. And this is something you might have heard about already, or it might be something you already even do yourself, but it involves providing an owner with a script for antibiotics with instructions only to fill it if the condition worsens or does not improve within a certain amount of time. And this is most effective for specific conditions like viral URIs, and it's effectively used in human medicine. And it's really quite effective because it empowers the client. It doesn't make them feel completely helpless. It gives them options, but it potentially avoids an unnecessary course of antibiotics in the animal. And in this one study where we interviewed pet owners, we specifically asked them what they thought about this kind of initiative. And for the most part, it was very well received. This particular owner says it's a great idea because if you go in the vet office, things can be fine, but then overnight you get home and all hell breaks loose. So she likes having her options. And this other owner said that they liked it because what happens to them often is he comes to the vet and the pet acts completely normally. And then the other 23 hours of the day, they look different. So they would be happy taking that script home. So another really useful tool. And finally, if we're going to be bringing clients on board as partners in judicious antimicrobial use, some studies have found the use of peer influence to be really effective. And so these two studies looked at the issue among dairy farmers, both in general and for the specific issue of adopting selective dry cow therapy versus blanket dry cow therapy. And what these studies found is that talking to dairy farmers about peers who have adopted more judicious antimicrobial use was quite effective in motivating them to pledge to adopt stewardship measures themselves. In another study, one of the parameters that determined farmers' motivation to consider selective dry cow therapy was whether or not they can still consider themselves good farmers in the eyes of their peers. And if they could, they'd be more likely to consider adopting this kind of technique. And other examples of this type of peer influence, both in the socio-behavioral and the medical literature, exist. And peer influence therefore represents a type of leverage that can really be used to achieve behavior change geared at promoting more judicious antimicrobial usage. So let's go back to some of our other factors, and let's move on to the big elephant in the room, which is cost. And unfortunately, I have no magic answer here. Cost is a real and true issue. And even when pet owners have pet insurance, for example, or other contingencies, it can be really difficult to persuade clients to pursue diagnostics that might achieve a better stewardship outcome. And what we've learned from our research is that when we're talking about costs, there are generally three groups of clients. There are these clients up here that are, on board, they're full-fledged support, they're completely on board with spending any amount of money to find out what's wrong with their pets, and they're okay running a culture and sensitivity to achieve the best results. And these clients are not the ones you need to worry about. Then there's another group of clients who just cannot justify the costs for more extensive diagnostics, and most often it's because of true financial limitations. However, there's this middle group of clients who can be persuaded and who it would really behoove us to overcome our reticence to push diagnostics to truly bring them on board. And so when we presented them with a hypothetical clinical situation, and we were trying to persuade them to pay for a culture and sensitivity to support judicious therapy, we found that there was a pretty healthy third of pet owners who could be persuaded. Notably, they said, is it something major? Yeah, I want you guys to nail it, spot on first time, get him what he needs, and sure, instead of trial and error and saying, hey, doc, 7 days just isn't working, try something else. These kind of clients could be persuaded with the proper explanation on board. And so while I really wish there was an easier answer for dealing with the issue of cost, I would encourage you to really commit to testing the waters with your clients and giving that explanation a true shot, because you might be surprised who agrees with it and who agrees to go for it. So let's get back to our factors here. Let's talk a bit about defensive medicine, okay? And defensive medicine is also known as just-in-case medicine or CYA medicine, and it can lead to unnecessary antimicrobial prescribing. And literature has shown that defensive medicine can come from a fear of liability, but also a lack of confidence. And while there's not much we can do to address the liability issue, the issue of confidence can be addressed by empowering clinicians. And this is something that we can especially do in our roles as mentors to students or young graduates. Empowering a clinician to be more confident in his or her prescribing choices can limit their need to practice defensively and potentially prescribe unnecessarily. And I'd just like to share a few tools that we use to do this in our institution and in other institutions that may be useful to you in overcoming a need to prescribe defensively, whether your own or that of a mentee's. And these tools are intended to provide clinicians with a firm foundation from which to be good stewards of antimicrobials. They're not necessarily there to help on a case-by-case basis, where the pet or client in front of you, wants to have those unnecessary antimicrobials, but it serves to provide a basis that enables clinicians to more confidently make that call that antibiotics might not be necessary. And so in our veterinary curriculum, we specifically introduce concepts that are important for stewardship and that haven't always been traditionally taught. So for example, the conventional wisdom that we've hammered home in our graduates for the longest time is that patients must complete their course of antibiotics. And if they don't, they'll be underdosing and promoting antimicrobial resistance. But this notion is being reevaluated in favor of alternative options like antibiotic timeouts. And so especially for hospitalized patients, instead of blanketly prescribing a 7-day course of antibiotics and sticking to it regardless of what happens, we now recommend evaluating the patient at more regular intervals and consider stopping the antibiotics if a patient seems to be doing better clinically. We also strongly advocate for de-escalation from broad spectrum to more narrow spectrum antibiotics based on diagnostic test results, even though it might be challenging to do so, especially if the patient's not hospitalized and they've already gone home to their owner. We also recommend transitioning from IV to PO meds as early as possible, though I suspect most vets are already doing this because IV meds tend to be more expensive, and anytime we can avoid complications associated with IV access, we will. The second thing here, this soda pop mnemonic, is something that one of my colleagues who teaches students on clinics developed. And it's an aid to thought and guideline in guiding antimicrobial prescribing. And it's this mnemonic that has the student consider the source and the organism before deciding to treat, then considering the antimicrobials to which the organism is susceptible with regards to contraindications in the patient. Ultimately, we weigh our options and formulate a plan. And he's actually currently conducting a trial to see how effective this method is with vet students. But it's generally agreed with great enthusiasm by students, and they really appreciate kind of having this aid in thought. And this kind of thing can really empower a clinician to be more confident in their decision making. And as mentioned previously, other institutions have sought to empower their clinicians by providing them with guidelines, not just for antimicrobial use, but also for when to conduct different types of testing that could further guide prescribing. They also have some really useful institutional forms and templates that can be useful in having a pipeline in place for example, more confidently making the no antibiotic call. And so this is an example of a form that clinicians can hand out to owners when their pet does not need an antibiotic. And it explains why their pet does not need antibiotics, and it explains what to do instead. And it really saves the clinician the time and the trouble of having to develop this spiel from scratch, and having something on paper really can empower both the clinician and the client to be confident that this is a legitimate course of action, not to be prescribing antimicrobials. And finally, a tested method to enable clinicians to more confidently say no to inappropriate prescribing is to promote clinician accountability through the use of pledges or commitment posters. And these are pledges basically that clinicians make to use antibiotics responsibly. They typically sign them, they put their name up there, they put their photo on there, and they hang them in their offices or in their exam rooms and that sort of thing. And this technique can be very effective because it takes advantage of clinicians' desire to be consistent with their prior public commitments. And also this way, clinicians know that patients have seen the poster before their visit. So clinicians take this purposeful step of making a public commitment. Clients see these posters and they're less likely to question his decision not to prescribe antibiotics. And in one particular study in physician practices where these posters were posted, compared to control practices that put up standard CDC educational materials, the pre-commitment posters were associated with a 20% absolute reduction in inappropriate prescribing. So they can be an effective method for clinicians to kind of short circuit the urge to practice defensive medicine, because they've already made this very public commitment for which they can hold themselves accountable. Now, most of what I've talked about previously has been stewardship that can be undertaken at the grassroots level, at the individual level. And I want to touch very briefly on initiatives that can be taken at the institutional level, because while I realize not all of us are in a position to be able to influence things at the institutional level, some of us do work in academic institutions, some of us can sit on antimicrobial stewardship committees, and therefore some of these might be helpful. And the hope is that some of these could eventually be incorporated into clinical practice on a more widespread basis in the future when they've been established in other institutions. Now, I'm going to skip this because this is the general pathway that's recommended when starting an entire stewardship program from scratch within an institution. And it's really beyond the scope of this study, of this talk, to walk through it. Instead, I'm just going to present a couple of initiatives that have been demonstrated to be successful and can be implemented at the institutional level. And the first of these, which you've probably heard of, is formulary restriction. And it's an initiative that involves limiting what a prescriber can prescribe, either by completely restricting its use or requiring certain criteria to be met before this antibiotic can be prescribed. And it's usually usually reserved for the big gun or critically important antimicrobials. And while this might appear really to be nanny state or big brother to veterinarians who generally don't like being told, let's be honest, what to do, it can be effective in limiting the emergence of antimicrobial resistance, which of course is our ultimate goal in promoting judicious use of antimicrobials. And in these two studies that were, in these studies here, actually restricting certain classes of antibiotics could result in decrease of the emergence of resistant organisms within the hospital setting. So done carefully and considerately, this method can be effective in limiting, especially the use of broad-spectrum antimicrobials. And some vet clinics just do this anyway by just not even purchasing certain antimicrobials, which can be effective. This one I'm only going to briefly mention because at this time, given the state of veterinary electronic medical records, it's a bit of a long shot. But it is something that could potentially be implemented in an institution where IT and clinicians work together well. There's just a really large variety of electronic alerts, such as bug-drug mismatch, inappropriate double coverage, this sort of thing that an electronic medical record could automatically alert a clinician to limit potentially ineffective or unnecessary treatments. To my knowledge, no such alerts have been implemented in any veterinary settings, but in human medicine, they have been associated with decreases in both total antibiotic use as well as use of broad spectrum antibiotics. So a potentially interesting initiative that could be implemented in places where, again, the EMRs allow it is peer comparison via audit and feedback. And in an audit and feedback process, an individual's professional performance is measured and compared to professional standards or targets. In other words, their performance is audited. And then these results are fed back to the individual. And the aim of this process is to encourage the individual to follow professional standards. And it takes advantage of people's basic desire to conform to social norms and to respond to emotionally laden messages. Many studies in human medicine have shown that this type of peer comparison can result in sustained decreases in prescribing. And to my knowledge, no studies have been completed in veterinary medicine, but there are some planned studies underway. This graph on the left here is from a paper describing just such an initiative that's planned in a series of outpatient veterinary clinics in Israel and Canada. So stay tuned, hopefully we'll get the results of that soon. On the right here is a diagram from a personalized antimicrobial use report that I developed for veterinarians in our hospital. And these reports were presented to each individual clinician, and we basically gauged their reaction to the report in general. The general perception was that the veterinarians liked them for the most part. This one veterinarian said this: "My initial impression of the report is I'm proud of myself. It's kind of fun to see how you compare to other people in the population." So vets liked seeing their performance relative to their peers, especially if they were on the lower end of the spectrum. Now, there was a bit of a mixed bag on whether this type of report would actually change prescribing behaviors. Some vets thought they were already prescribing as judiciously as possible, while others, such as this person, acknowledged, yeah, absolutely, this report would change how I use antimicrobials. I do think that, we all learn in different ways. And I think this giving us a visual representation of how we compare really does impact people a lot. So again, this is something that has potential for to be a good initiative moving forward. And finally, one of the initiatives that can also be done at the institutional level to guide prescribing is one that has currently been undertaken at Ohio State, and this is the surveillance of antimicrobial resistant organisms within the hospital setting with the periodic release of antibiograms. And this is an antibiogram here. It's basically just, they culture different bacteria and they see what they're resistant or susceptible to. And it gives an idea, a snapshot of basically who is resistant to what within the hospital. And the idea is that if one needs to treat empirically with antibiotics, this kind of information can help guide a clinician to make the most educated best guess on what to treat with. And obviously this takes dedicated personnel, laboratory equipment, and resource, but it's the kind of thing that's increasingly being considered more and more to promote the judicious use of antimicrobials. Now, I certainly don't want to end on a completely pessimistic note, but I do want to acknowledge the realities that antimicrobial stewardship can be challenging to pursue in veterinary medicine, especially compared to human medicine, right? So in human hospitals, there can be a lot more resources dedicated to stewardship. And there are very real external pressures that can make it so that a hospital has to comply with stewardship. And these pressures don't exist in veterinary medicine. Other things veterinarians have to deal with that human hospitals don't are things like the cost of microbiological testing, which has to be borne out of pocket by most pet owners. And then the lack of independent evidence-based guidelines for specific conditions in veterinary medicine that make it harder to know what actually is judicious prescribing. That being said, I do think that there's real opportunity, and perhaps most importantly, there's real desire among veterinarians to engage in stewardship. And you all attending this seminar is proof of that. So in some cases, we can certainly draw on the decades of experience in human medicine to inform what we can do, while in other cases, we'll have to forge our own paths because the unique nature of our practices makes it so. But I truly think that we're in a pivotal moment in the history of veterinary medicine where the desire to engage in stewardship is stronger than ever. And I would encourage you all to engage whenever, wherever, and however you think would suit you best, and to draw on the increasingly extensive resources that are available to practitioners that are out there to really promote the judicious use of antimicrobials. And with that, I'd just like to leave you with these quotes, and I'm happy to answer any questions you might have. And thank you for your attention.
Thank you, Dr. Redding. There were a few questions that were posed in our Q&A feature, and I'll just read those off to you if that's okay.
Sure.
First question is, you referenced a study by Banfield early on in your presentation. Is that data published anywhere with public access?
Yeah, absolutely. Those two are publicly available. And if you search, I think if you just search a Banfield State of the Pet report or Banfield Superbugs, you'll find those two reports out there. They are publicly available.
Well, thank you. Another question is whether you had an opinion, and if so, what is your opinion of the accuracy of resistance determination based on genetic coding, PCR, versus waiting for a culture and sensitivity?
Oh, goodness. Wow, that's a really, really good question. That's not my area of expertise, so I'm not gonna delve too much into that, but I do know that that kind of work is increasingly being used. There was a study recently that looked at environmental resistomes on swine farms, and I think it compared it to standard culture methods, and definitely those methods are a lot more sensitive. So I think, if we're trying to pick up or, develop these antibiograms and we're looking for really good specificity, then those methods are probably going to be the way to go. But in terms of their feasibility and logistics, I think they're challenging and certainly won't be for every practice out there. Most practices just don't even have the resources to do those things. So yeah, thanks for that question, though. It's a really interesting one.
Okay, another question is, can you explain further the antimicrobial break? Is the recommendation to stop use before the prescribed regime is completed?
Yeah, the antibiotic timeouts. Yeah, so I mean, it's a new thing. It's a relatively new thing, right? Because as I mentioned before, the conventional wisdom has been, absolutely complete that course of antibiotics, and if you don't, then you're promoting resistance. And there's just, we're reevaluating that, and there's some evidence to suggest that, we don't need to do those entire courses, and some of that is derived from human medicine. But basically, what we do in our hospital is, any hospitalized animal that's on antibiotics, we evaluate them, on a daily basis. And we look at their clinical parameters, we look at their lab work, and if things are really moving in the right direction, like for example, if fibrinogen is down significantly or a white blood cell count is down and the animal is doing much better clinically, then yeah, we'll stop that course of antibiotics early on. And it's a lot easier to do in a hospitalized patient where you can monitor it closely and you're getting access to this routine lab work all the time. But it can also be done on an outpatient basis if you have a really dedicated owner, and you're really dedicated to, to reevaluating that. And so I think, this is another area where more research is needed to kind of demonstrate that it is feasible and to kind of overcome this long-standing thinking that if we don't complete a course of antibiotics, then we're doing it wrong. But I think this is something that, is a good thing to explore going forward. And these antibiotic timeouts, like I mentioned, they're done in human hospitals all the time. So it's time for us to start moving in that direction too.
How should clinicians advise owners when detecting AMR infections such as MRSA in pets?
How should they advise them in terms of where it came from, or in terms of like preventing transmission between the pet and the owner? Well, let me just throw it out there.
Mainly, and she clarified, the above question refers to public health advisement. Should we have any advice with regard to those resistant bacteria from a public health perspective?
I guess I would say if you have like a specific pet owner in front of you and their pet has a resistant organism, I think I would, caution with all of the same cautions that I'd use for, any zoonotic disease, and that, this is an organism that can be transferred between the pet and the person, and, standard kind of hygienic measures should be instituted, hand washing, that sort of thing. If you're changing bandages with an infected wound, maybe wear some sort of PPE. Limit, cuddling with that animal during that time. I have seen cases of that myself in clinical practice, and often, the pet owner thinks that they actually gave the resistant organism to their pet, and we don't really know the directionality of transmission at this point. But I don't know that in terms of resistant organisms, there's that much more we need to be addressing beyond what we would normally address for a zoonotic organism. But it is also a good teaching moment to kind of, emphasize that the unnecessary antibiotic use of antibiotics can contribute to this sort of thing happening.
Right. And then one last question. Is there any research around client willingness to accept and veterinary knowledge in how to prescribe alternative treatment modalities instead of antimicrobials? For example, topical non-antimicrobial treatments.
Not to my knowledge, not in the pet sector, not in the pet arena at all. I know that there's a lot of research in alternatives to antimicrobials in the livestock sector, and I don't know specifically if there's been any consideration of what farmers think about these alternatives, but I suspect some investigations must have done, but just off the top of my head, I'm not familiar with any. Great question.
All right. Well, I thank you very much for your time, Dr. Redding, and for answering those questions. We had a fantastic turnout, about 170 people at the peak of our presentation. So I do appreciate everybody attending. Well, wonderful. We had very good turnout. We have very positive comments in the chat section. I will send those to you, Dr. Redding. Once again, CE certificates, we should be able to send those out within the next week or so. And keep on the lookout for future events, and also keep on the lookout for future speakers. We will take any recommendations or volunteers to present topics such as this to our membership. So once again, thank you for attending.